Okay. Good morning, everyone. It's Melissa Andrews with LeadingAge Virginia. Thank you for being here today. We know that this topic has more questions than answers at this point, and totally feel all of your pain with how quickly CMS has put this out and how quickly they're hoping we can comply. We're grateful to have Janine Fink-Boyle on with us today, the LeadingAge Vice President of Regulatory Affairs. Janine is knee-deep in this stuff all the time, so if anybody can provide us insight, it is her. If you have any questions, put them in the chat box. We'll make time for open dialogue after Janine's presentation. Janine, over to you.
All right. Thank you, Melissa, and good morning, everybody. As Melissa said, I know this has been fast and furious, and today is September 2nd, so today is the actual registration of the implementation of the interim final rule. So to get right into it, I'm going to go through some of the highlights between the interim final rule with comments. There are two memos, which is the QSO memos. It's 20-37 and 20-38. So I will reference what's in those memos. And I know that Dana had sent out, I think earlier this morning, links to everything that I'll talk about, along with some tools that Jody has put together and I've been working on regarding the antigen testing, some summary articles. And so those are all in the link if you want to kind of click on them as I talk, or you want to just hear me kind of go over everything, and then we can discuss, as Melissa said, questions at the end. There's still some questions that we know that we've been sending up to CMS, and we'll also try to collect some from you today as things roll forward. So on the 25th, CMS released the interim final rule. That interim final rule actually outlines testing requirements for nursing homes. As that final rule, it's a final rule with comments, and I'll talk about the comments just for a second. The 60-day comment period allows us as members, as all of you as members, excuse me, as us as an association, providers can send comments into CMS. We will be sending in comments, and we're working on not just a template, but some of the bullet points that we've been hearing from members throughout the country in the last week, and what we've been discussing too regarding through our advocacy. So look forward to that in the next couple weeks. The comment period will be due by November 2nd, but we'll have things out beforehand. Once the final rule was released, the next day there were detailed guidance that CMS put out in the two memos. The memos actually outline the testing procedures, the outbreak response, the documentation, reporting requirements, and survey procedures. As you know, the survey was, as a prioritization was put forth, and things were changed in the survey process in the last few months. CMS also then had gone back and has released that they will be doing on-site surveys again for annual visits and then revisits with IJs. So we need to think about that as you're putting your now new testing plan together to meet and be compliant in the interim final rule. The other memo that CMS put out has to do with CLIA. So knowing that you need the CLIA waiver to run the testing, we'll talk about that in a second, for reporting the point of care testing that's conducting from your nursing home. So why don't we just jump right into it? So as the interim final rule was put forth and the guidance memo, it is outlining that nursing homes need to have required testing for staff. There are also triggers with testing requirements having to do with if there are residents and staff, I should say, show symptoms, that facility-wide testing must be completed. If there's an outbreak for those particular residents or staff in your organizations, that testing needs to be completed. If there is an outbreak, and an outbreak is considered one new case among nursing home staff or nursing home onset case among residents. Now remember, as the requirement is to conduct routine testing. So what type of testing needs to be done? It's the PCR or the antigen testing. That is what has to be part of your compliance for the regulation, not the antibody testing. As the initiative from HHS that came out here over the summer, those machines that I know some of you have been placed into your organizations already. The other organizations that might not have a machine yet, we understand from HHS and CMS that those will be all delivered by the end of September. And we'll talk a little bit about, if you don't have one, what the options are. So with the requirement for testing staff, what does that include? That includes your facility staff. So that's obviously your employees, so your full-time, your part-time, your per diems. It also includes consultants or contractors or volunteers. So any of the facility staff that's in your organization. It also includes students. So students that might be in your nurse aid training programs or from any other affiliated programs, so social work or activities, maybe you have an administrator in training. So that's the definition of facility staff. I think what's important is, and what we've been really asking is that how that works, especially with if you have hospice coming into your organization and is the nursing home testing? If the nursing home's not testing, then the hospice staff, I'm using hospice as just the general contract worker that you might be using, then they would be tested by their hospice and make sure that documentation comes to the organization because there's the documentation part of the requirement. With the testing frequency, there's the 3 triggers, whether it's symptomatic, so any staff or residents who have signs or symptoms, and remember working and looking at what CDC has for signs or symptoms of COVID-19, that those staff or residents need to be tested, but you still, if there's no signs or symptoms, you still need to be doing screening. So screening is still part of the process that you should be doing. Again, that's how you're finding out if there's symptomatic residents or staff. If another of the trigger is the outbreak. So if you have an outbreak in your organization, then all residents and staff need to be tested. And that is, again, the single new case or single new infection in staff or the onset infection of the resident. And with that, then the staff need to be continued testing and testing for the period of at least 14 days from the most positive result. The residents have to be tested negative every 3 to 7 days. Now, the other part of the requirement is the routine testing. So routine testing, and this is going to take a little bit of a turn, that your staff have to be tested based on the virus in the community. And so what CMS has put forth is they have intervals varied by community COVID, the activity level. And so there's a chart that is linked into the article on our LeadingAge .org website, and the community activity is broken into low, medium, and high. So what CMS isn't saying, oh, okay, you should be testing X by X. What they're asking is that you as an organization monitor every other week the positivity rate in your county. How you will find that is by looking at the data.cms.gov and see where your nursing home is located in that county and see what the county positivity rates are. And from that, then you would see, is it less than 5%? That's low. Is it 5% to 10% is medium? And then the high is over 10%. And there's a minimum testing frequency. So once a month for low, once a week, or then twice a week for high as it goes through. And that's using the point of care testing, or again, as I said, if you don't have the point of care testing yet, you would be using an outside laboratory, and the turnaround time is 48 hours. I know we've had lots of questions about that 48 hours, if that can't be met yet. And so we'll talk a little bit about that in a bit. So again, with the routine testing, you need to follow the data.cms.gov for every other week for the positivity rate in the county that your nursing home is in. With that, that testing frequency, as I said, is outlined in a chart. And then your nursing home will choose if you need to increase testing based on other factors indicating what's going on in your state or your local mandate or community prevalence in any neighborhood counties. So where that leaves your organization is to start a testing plan, to start a testing policy and procedure, and have that available along with documentation. So as you test staff, those testing results have to go in the employee record. As you test residents, that goes into the resident medical record. Those outlines of the documentation is also in the rule, also in the outline of the memos. Looking at when was the resident or staff tested, what's the results, what action was taken, if they were symptomatic. The other part, if there's an outbreak, where was the trigger, when was the trigger identified, what were the dates of all the residents or the staff tested, and then the retests and the results of those tests. For routine, again, you're documenting what's your positivity rate in that county, and then showing what your corresponding rate frequency. So in some cases, you might actually have your policy, and then you would have what I would think is that more of a rolling parts as things might change in your organization. Now, what happens if a resident or a staff refuses? That is also outlined in the memos. What we'll say is that there have to be procedures in place. So this is also part of your testing plan and your policy and procedure. So what is your organization going to do if a staff decides to refuse the testing? And then how you do need to look if there was an outbreak, but you don't have that staff from entering the building until the return to work criteria are met. Again, looking at what CDC guidelines are. If the resident refuses, that you have to have procedures in place for the resident refusing testing. If they have signs and symptoms and they're refusing testing, that they're put on your transmission-based precautions, and that's until there's any of the criteria to discontinue have been met. If there's outbreaks and the resident also is refusing, and in that particular case, the facility really needs to make sure that you have additional monitoring, making sure that PPE is being used, and having hand hygiene. With all of that, as I said before, with the refusals also need to be documented. So you're documenting your testing results. As we said, we went through whether symptomatic, outbreak, or routine. But then if there's a refusal in any of that, you need to make sure that you're documenting in that. So how is that all going to play out in your organization? Well, as you go through the other parts of the memo, as you see that CMS has now implemented a new F tag. So falling under the infection control tags, the new F tag is F886. So it will be, you could be cited for non-compliance for documentation. And with that documentation citations that you could receive, there's enforcement remedies. Of course, why would there not be CMPs, right? They'll be based obviously on the resident outcome, and the scope and severity will be on non-compliance. So whether you're getting an isolated incident, a pattern, or widespread. And so with that documentation, you need to make sure that you have your policy, you followed your policy, you followed your plan. If you have an outbreak, just as everything that I talked about before. Again, unfortunately, with the testing requirement, there can be penalties. So that's a part that really make sure that you look at, that you're hitting all of the pieces for documentation. Another piece that comes forward as you move to the other memos, so between the 37 QSO memo and 38 QSO memo is working on the CLIA. So again, knowing that you need a CLIA waiver to run the antigen testing in your organization. So if your nursing home is running the testing, you have a CLIA waiver, you've met the CLIA requirements. The other part of the CLIA requirements is the reporting. And so knowing that you're reporting, and I know we've talked a lot about this on our daily call, we have outlines on our leadingage.org website following when the HHS started the initiative to send out the antigen machines. And I know there's an FAQ from June 4th if you actually search on that. So having the CLIA waiver, doing the antigen testing means that you need to report. And with that reporting, I think there's 18 pieces that you have to report. And without complying to report, again, with also the NHSN, so you're reporting to NHSN, the citations you can receive on CMPs could be $1,000 each week for non-compliance, or an incremental increase of $500 per week. So for failure to report. So you must continue to report your COVID data. That's also, part of the initiative. Make sure you have your CLIA waiver. We also have links to applying for CLIA waivers if you don't have them. And then with all of this, so as CMS has revised the focus surveys, they have looked at now coming in for annual surveys. that compliance for testing requirements, they have gone back in and updated that focus survey grid, so the pathway, and we have that listed also on some of the documents, that not only with the memo, but also with what I think Jody had done last week. And so remembering that all of that is part of how your surveyors will come in. They will look at, again, the required documentation related to testing. If it's symptomatic, if there's outbreaks or routine testing, they're going to look at all of your policy, procedure, and plan. They will be looking at reviewing the records of the residents and staff, probably a sample, just like you would do to pulling HR records and as they're doing sample of medical records for residents. And then they're going to do observations. And so those observations, not just hand hygiene and donning and doffing PPE, but they'll be looking at observing staff and asking staff questions, interviewing the person that, if you have one individual, if it's your infection control preventionist that's responsible for testing and determining if you've met the requirements. I'm going to move one other piece. I just want to make sure that I go back 1 second on that 20-37 memo, which is the CLIA. I think that there's the memo itself does a really good outline. With your organization using the antigen testing in your facility, you have point of care, you have rapid results. Now, if for some reason you haven't received the manufacturing device and the kits and so forth, and you're using an outside lab, what that is that you need to get those results within 48 hours. And as I said earlier, we know that there are barriers to that there are particular issues with outside labs, getting tests 72, sometimes, a week and so forth. What you need to do is you need to then actually talk to and make sure that your Department of Health, in this case in Virginia, is aware that you're not getting the results within the 48 hours because you'd be out of compliance. That needs to be documented. It needs to be documented that you're not getting the results. It needs to be documented that you have who you spoke to and you've given that information to in your Department of Health. I know that there's different labs out there that you could choose. Again, they're all over the place, but that is something where your documentation has to be on spot and that you've given that information to your state Department of Health. And I know that there are lots of our members that might be using it in an outside lab for the PCR or the antigen testing. I think I hit all the high points. I don't know, Melissa, Dana, Paula, if there's anything that that you might have. I wasn't looking at the chat, but I can right now.
Yeah, we've got a lot in the chat, Janine.
Okay. Yeah.
And one additional question I have that has come up recently: has CMS talked at all about requiring surveyors to be tested?
No, they have not. Well, I should say, let me back up for a second and answer that in a different way. We have brought that forward to SEMA Verma directly.
Yep.
And SEMA Verma has stated publicly that they're taking their precautions using their PPE, but right now they are not requiring the surveyors to be tested. We are working through our channels, advocating, really looking at how we can try to push that. So any pressure you can put on from the state level, working with your state Department of Health would be helpful.
Okay, that's duly noted. Do you see the chat box, Janine, or do you want me to read them all?
I do. I just opened it up.
Okay.
Okay, so I'm going to start with residents required to be included on the initial testing even if all residents are asymptomatic. Let me see. Residents required to be included on all the initial testing. My understanding is that it's for symptomatic residents, that not asymptomatic residents for the initial testing. Should we handle reporting positive and negative cases to VDH in light of the portal not being created as of yet? Let's see. So I'm just trying to follow up on that. So reporting the cases, what I would say is, as you have your documentation, if there's a way to ask the Department of Health if you have to send something in through another secure method. I don't know if the email I know is not secure, but if you document it with VDH that you have them, I don't want to speak for VDH because I don't know, but what I would say for your organization is you need to have your documentation, and then you need to tell someone at VDH that you have it, so that we have something to back up.
Is anybody from VDH on the call that could speak to that?
Hi, this is Shayna. Can you hear me?
Yes, Shayna, thank you.
Hi, yes. So we are aware the timing just isn't necessarily working. We have this new portal that's going to be going live that will, in response to the reporting requirements. Until that occurs, we ask that you continue to use the VDH electronic morbidity reporting portal to submit positive results. And then to meet the requirement of reporting sort of all results, you can document all your negative test results and send them to the local health department. How you would like to send that, via that fax, and you have that documentation, is up to you. This is sort of just in the interim, again, until we have this electronic portal that will accept positive and negative results for point of care tests.
Okay, and there's two questions I can put together, having hospice staff and agency staff. So with hospice staff, and I see that hospice doesn't seem to know anything about this, which is, I think about, my days working as a provider. It's the nursing home's responsibility to make sure that they know, because the nursing home is the one that's going to get the citation if things are not in compliance. So with hospice staff, it's that your organization can choose to test the hospice staff, or you can ask the hospice to test, and then the hospice would need to bring you the documentation for that hospice staff member. And so what I would do is I would have a very open conversation with the hospice executives, or the person that is in charge of whether you're using Hospice X. I'd make sure that they have copies of the memos, that they have copies of the interim final rule. Please feel free to share any of the documents that we've put together with the hospice to make sure that they understand that they have to meet this requirement, and that you can help them meet it, or they could meet it, and then you have to document it. When it comes to agency staff works like, I consider them more like as a consultant, but they're in your organization, they're working with your residents. So anyone that crosses that threshold and is in your building, they also need to be tested, and that they also need to be documented. I think with agency staff, you have a contract, but then the agency holds the employee record. So, but you still have usually an occupational health record on that agency staff. That's where that documentation, should be. The positivity rate on the CMS site versus our county is different. What should we use as a guide? Right now, what we've been understanding from CMS is that you should use the CMS site for the positivity rate. If that changes, and the hope is that we're supposed to have a call with CMS today, and we'll bring that up, I will make sure that you know. All right, I'm gonna scroll down, there we go. Oop, I went a little bit too far. X-ray techs and pharmacy delivery staff. So X-ray techs are actually coming into your organization, and they're doing an X-ray on a resident. And so in that regard, you would need to have testing results on them. I'm assuming the X-ray company would be doing it. The pharmacy delivery staff, they're filling up your med carts. They're on the unit. They're on your neighborhoods, on your units. You would also need it from the pharmacy delivery staff. Again, I will double check with CMS, but the way that the memo is outlined is, as I said, it says, consultants, it says contractors, and that they would fall under that overarching category. As to the positivity rates on the CMS website accurate, I don't know the answer to that. Again, that's something I can ask. Hold on, I'm gonna make sure I get that one on my listing with the other one. In the RC definition of testing employees, wouldn't we only test those employees and others that are in the CMS certified nursing home, not independent living or assisted living staff? So Jody and I have gone back and forth on this. We were talking to some members yesterday. That is how we understand it. We understand it, again, it is the staff members that cross that threshold that work in the nursing home that have whether direct or indirect care in the organization of the nursing home that's certified by CMS. I think we had gotten a question yesterday about a cook that would be in the independent living. Well, if that cook in the independent living is an IL, that's more like I'm going to put this in quotes, that would be like a public space. That would not be someone that's in the dining services part of the nursing home. I hope that answered that question. How should we calculate the positivity rate in light of staff traveling from other counties? Hold on, sorry. Do we need to calculate the percentage of staff living in other counties and weigh accordingly, or is it solely based on the county's rate where the nursing home is located? So my understanding, it's solely based on where the county's rate where the nursing home is located, but I will definitely follow up on that with CMS. That I do not have a direct answer for that. But though that, you bring up really good points, Nathan. Under the testing summary for routine testing, under the column for residents, it states for residents, routine testing is not recommended unless the resident leaves the facility routinely. Please clarify, do you need to test all staff and residents or just staff? So remember the triggers for the testing requirements have to do with symptomatic. So if there's a if there's a resident or staff that's symptomatic, if there's an outbreak, in your organization, so though you need to use, those are the triggers for testing. If you have a previous positive employee who has been 90 days since positive test, the routine test still results as positive. Do you count that as new case of COVID, or should you have them tested for antibodies to verify IgM versus IgG? That is an in-depth question that I do not have an answer to about through over the 90 days, because you're past the fact that would you know if they would have antibodies. I'm going to take that one back and actually talk to our CDC people about that one. So I'm sorry, Elaine, if that's right, but I will get an answer to that one. So I'm hoping that the CCRC question, the way that I answered it, answered the question about the wellness office. Our wellness office is not licensed as an independent living. It is at our rehab and nursing homes. Our wellness nurses, both RNs, are allowed to administer a COVID test to a resident if you don't have a licensed clinic. That's a good question. So I think, so Kay Moore sent that in. So the wellness center is at the rehab and the nursing home. Their RNs, can they administer the COVID test? I am not comfortable saying yes to that. That's something I need to just make sure on that particular question. So I'm sorry about that. I just want to make sure. All right.
Janine, I wondered if there was anybody from the Department of Health that might want to comment on that.
This is Shana. I can comment on the previous question. What's the current question as well? Can you repeat that question?
So I can repeat the previous question having to do with the 90 days with the previous positive employee. Is it that one? You can answer that one?
Yeah.
Okay, perfect. Yeah. So the previous positive employee who has been 90 days since positive test, the routine test still results as positive. Do you count that as a new case of COVID, or should you have them tested for antibodies?
Yeah, so the CDC in their FAQ that they talk about sort of reinfection, and it's really the CDC's guidance that talks about the sort of 3 months after you're positive, you don't have to be tested again unless you're symptomatic. But then after that 3-month time period, then those individuals would still be included in the staff screening part, whether it's reinfection or continued positivity, it's kind of unknown. You're going to have to look at kind of the clinical context and sort of what's going on in the facility. So they kind of have, the CDC has a section that kind of addresses that in their CDC FAQ. So I would definitely encourage you to read that part. And then our state public health lab is interested in getting those specimens from individuals that have this potentially reinfectivity or persistently positive. It is rare to have a 3-month time span where you're persistently positive. And so that's kind of why the cutoff of 3 months was chosen, because we shouldn't have that many individuals that they've seen from all the data that they have that are continuing to be positive after 3 months. So if you do have an individual, definitely follow up with your local health department because we do want that specimen. And then how you treat them as far as infection prevention is, again, going to be based on if they were symptomatic, what else is going on in the facility, the prevalence in the community, if you would sort of act as if they are a new infection or not. So it is going to be case dependent in that situation.
Okay. And then the other question about the CCRC, that the CCRC is on a different campus from the independent living, but the wellness office is not licensed as an independent living. It's at the rehab and the nursing home assisted living campus. So could the wellness nurses who are registered nurses, can they administer a COVID test to a resident if they don't have a licensed clinic? Or would it have to be handled by the rehab AIL campus?
I would believe that would fall all under the scope of practice laws in Virginia for, nurses and what they can and can't do. If, they're basically, it sounds like then that would just be like a contractor, if you contracted with Better Med to have someone take their specimens. So I'm not the person to answer sort of those types of questions, but it would seem, it's under their scope of practice, and as long as there's they're trained and there's sort of documentation about that should be okay, because you are allowed to have sort of outside contractors come in and take specimens.
Mm-hmm.
This is Dana, and I would agree with that as well about the scope of practice. We could reach out to the Board of Nursing to confirm, but I do think that analysis is correct.
What if your nursing home and assisted living are in the same building? Would AL staff need to be tested also? So remember, the interim final rule and the CMS memos are for certified nursing homes, and staff that work in the nursing home. I think what you need to take into account is that are any of those assisted living staff, again, I use the word crossing the threshold, are they coming in contact with any of the staff in the nursing home or any of the staff in the any of the residents in the nursing home? If it's separate and that's how it is, but this regulation, the documentation, the testing requirements are all for nursing homes. And I know that, assisted livings aren't receiving, well, I should say, I know that it did come out that some ALs they're going to receive antigen testing. So I think you need to see what is in your organization and how it's set up. But again, this is for nursing homes. So Teresa, I see, Teresa, okay. So Teresa Mandela is saying that I believe the SNF must take into account both the county area where the SNF is located, plus the residence location of the staff member. Okay, thanks, Teresa. And as that, I will definitely make sure that I check on that, but thank you for putting that in there. Okay, we have a construction project starting on our SNF facility. The construction workers will not be in the living area of the residents in the SNF. Are we required to obtain certification from the contractor of testing of the workers, or do we have to test them ourselves? So they're not in the living area of the residents, but they're still going to be in the facility. So I think that is something that you can, choose to do. You can choose to test them, or you can have it would be like you'd be using an outside lab, but they would be testing. So that would be the same, I think, as I use the hospice example. Do these requirements take effect today or after? Nope, the requirements take effect today, September 2nd. for the final rule, the 60-day comment period is just the open period to make comments. And after that comment period, there could be changes. But as it stands today, it is September 2nd. The wellness nurse clinic is at the independent living. Can the RN perform the test at the clinic is not at the rehab center? I'm hoping that we answered, well, I shouldn't say not myself, but between the scope of practice answered that question. The instructions for the BD Veritor Plus analyzer indicate their clinical testing was completed on people with COVID symptoms and results may vary for people without symptoms. How do we reconcile using the point of care device as our team members who are asymptomatic? Julia sent in that question. That we've been back and forth with CMS on the manufacturer's guidelines and so forth. I don't have an answer about the reconciliation. I know that we've been bringing that up. I will find out some more information on that about how to reconcile. What about landscapers, administration, et cetera, without contact with residents? Should the employees be included in the testing sample? Well, landscapers are, that's a good question about landscapers. They're outside, so they're not technically an employee or a contractor that comes into the organization. I think what you need to think about with the landscapers is that when they are working in a garden where residents might go outside, if they have any interaction, and that, that's, I think, something that your organization needs to look at in the, if the landscapers are not able to social distance or their residents go outside and they're in the space of where a landscaper might be. The administration, so administration does, I'm assuming that administration, meaning your nursing home administrator or executive director, if they are working in the building and they're in the organization and you have an employee file on them, if I was running the organization, I would be testing the administration. That's coming from me. But if it's a corporate office or maybe not on the campus, and they're not coming into the building, then that you kind of have to make that decision. I am hearing we do have to test residents one more time as a baseline. Oh, Melissa, this is from you. Can we validate that again? I will validate that with CMS. I know that question has come up on that, and I'll actually ask Jody too, because she might have a direct line with knowing what that answer is. Can any testing be done this week prior to today be counted? For example, testing completed on Monday or Tuesday. That's a great question. We've had that question before. There's no outline in the guidance to say whether it's a Monday to a Monday or a Wednesday to Wednesday. That question we did send to CMS before today. We haven't gotten an answer on that. Because although the rule came out, but it's not implemented as of today, we'll find that out, and as soon as we know from CMS, we'll get that out to you. Does it have to be an RN to do the test? I think it has to be. I think what we're talking about has to be within the scope of practice. I don't know if there's any other, whether it's I know the order can be by a physician. There can be standing orders, but I don't know if it has to be anyone other than an RN. And I'm assuming an LPN or. Yeah. Or like a lab tech? Is that?
I think one of the agencies trying to respond.
Okay.
This is, well, this is Shannon. So again, this is the scope of practice, but what I've been told is that an LPN can do it as long as they're under the supervision of an RN or an MD or NP, MD, PA. To take the specimens, but again, that's kind of a scope of work practice, which is not my specialty in those areas. So something else to follow up on, but that is what at least I've heard on another call is an LPN can under the direct supervision of one of those other professions.
So that's all the questions. I'm just going to go back and just make sure that I have some of the questions that if there's anything I missed. I know I'm going to find out, and again, thank you to Teresa Mandela about the positivity rate with staff traveling. I'm just going to verify that. I think that we got the answer about the previous positive employees within 90 days regarding the antibodies. I think we have an answer to that. And I think that the scope of practice we talked about with the CCRC and this office, and we just talked about RNs and LPNs. And I think, Dana, you had brought that up to talk to the Board of Nursing. I know that about testing residents one more time as a baseline, I'm going to verify that. And then testing about that was done prior to today, so Monday or Tuesday, and waiting results, can that be quote unquote counted? I'm hoping I have, that's the questions. I hope I have.
Yeah, Janine, we have all the questions and we will send those to you along to Shayna as well. We will confirm with the Board of Nursing on the scope of practice questions and get back with everyone. I feel like all the answers that were provided from the Department of Health is the correct analysis, but it's always good for us to confirm with the board. I just wanted to see if there were any more questions. It looks like we have about 15 minutes left.
This is Shannon. Can I get a clarification on a question about the, there was somebody that asked there was a difference between the county positivity rate on CMS's site and on our state site. And so right now we do not list the county positivity rate on our state site. We are in discussion of doing that. So I don't know if there's a website that I don't know about, or you know, I just wanted to get some clarification on the discrepancy.
In the, well, first of all, in the reminder that we sent out today regarding the call, we included a link to the information to get the positivity results. As far as the question about that, we can send all of these over to you today. Did anyone who had that question want to speak up and talk about that a little bit more?
I would appreciate it, because I feel like this is going to come up, and I just want to make sure I know where everyone's pulling information from.
So my understanding is that there seems to be a lag. People are concerned there's a lag with the CMS data, that it's not the most up to date.
Yeah. What we heard is there's a 2-week lag on the CMS site. So we are aware of that. But like I said, currently, and I guess this is good to think about, if we want to report this county level percent positivity, to realize that there could potentially be differences because of the delays, and then what kind of can of worms that would open up when looking at the county positivity rate. So yes, I agree that we've also heard that there's lags in the CMS county positivity rate. If we decided to also release our county positivity rate on our LeadingAge dashboard, I would think we wouldn't have as much of that lag. So we would definitely need to think through that. But thanks for bringing.
So I think let me just clarify. I know there's a question on here. Are assisted living facilities receiving antigen testing kits? So we have brought forth to CMS, as soon as the nursing home initiative had come forward, that there are other providers through the continuum, and how that would be. And I know assisted living was one of them. To answer them actually coming tomorrow, but I know that we brought that forward. I do know that it was released yesterday that the Provider Relief Fund now has for private pay assisted livings to apply for the PRF funds. And with that general distribution, I know you can use that funding obviously for testing. Let me see. I see a couple more in here. Okay, Dana, you just put that. Rick, 2-week lag is significant. Why wouldn't we insist on real-time information? Believe me, we've been asking for that between the NHSN with CDC and CMS, and we will continue from the CMS.gov website side, the data.cms.gov. Okay. Okay, we need clarification under the guidance for F886. It states to enhance efforts to keep COVID-19 from entering and spreading through nursing homes facilities are required to test residents and staff based on parameters and a frequency set forth by the HHS secretary. Does this mean we test everyone or not, and for each set time or just the staff? So the way that we see the way that the outline on the memos is that memo is using the 3 triggers. So whether there's someone that's symptomatic, whether there is outbreak, and then the routine testing is based on the community positivity rate. So that's the way that it's written. We have lots of other questions to ask CMS regarding that, but that are the 3 triggers that we know. So the symptomatic is we are screening staff and test any resident or staff that have symptoms. The outbreak, remember the response to the outbreak is any single new infection. And then that is where you're testing all staff and residents, and you continue to test all staff and residents that test negative every 3 to 7 days until 14 days since the most recent positive result has passed. And then the routine testing is where you're testing all staff based on the community positivity rate. With all of that, there's one thing that I did want to end on, because with everything going on with the testing and the requirements, the antigen, the kits and so forth, and making sure you have your plan and your documentation. At the same time, CMS has put forth infection control training. Now, I know that I think all of you probably have heard that initially this training was going to be released later in September, but it was released about a week ago. And it was supposed to be tied to funding. So if you took the training in your organization, again, it wasn't that 50% of the staff, there was no actual kind of indicator that there would be funding that would come. We have not heard that, but they did release the training. And so it is a 10 module training. Some pieces are PowerPoints, some pieces are different information documents to read and go through. There's tests in there. It can be for all levels of staff and all staff that are in indirect or direct care, along with some modules that are mostly for administration. And so it's hand hygiene, it's PPE, it's talking about telehealth, it's talking about communication and emergency plans. And so really take a look at that. And with that training, they're using subject matter experts to have sessions. I think they're every Thursday. One started last Thursday. But again, it's something to look at and use and have, some people in your organization go through it. As soon as we find out whether it will be tied to funding, we will let you know, because right now it hasn't been released that way. And thanks, Dana, for putting that in there.
Yeah, I put the training link if anyone needs it in the chat box.
Right. And I just want to say, and I won't go into detail, this training through CMS is different from what I think people are also hearing about the Project Echo. There's going to be training through Project Echo. That hasn't come out through fruition yet, but I know that is being shopped around and being told to QIOs and QINs working in different hubs throughout the country. But this training is different from that. Some similarities, probably.
Are we able to ask questions?
Sure. I hope I can answer it. I could try.
Yep. Go ahead.
One of the questions that has come up with everyone who comes into the long-term care that has to be tested, what if we have like EMS come in, or, our X-ray techs? Do those people have to also be tested on those weekly tests that are required?
Well, the X-ray tech would fall under a contractor, and the way that the memo and the guideline is written, that they would need to have testing. So I'm assuming that the X-ray company is doing testing, and you could get the testing documentation from them and file that along with the contract that you have on the X-ray. EMS, that's a really good question. That's an emergency situation. And so, you're not going to be asking them for documentation as they're trying to do CPR. I will follow up on EMS and see. I don't know how CMS is, what they're going to say. CMS is also there. They sometimes, I think you know this through when we were doing visitation and communal dining and activities, they always say that's the health and the safety and well-being of the resident. But I understand with EMS, it's an emergency situation. So I will find out about that.
And then one more, the medical transport that brings the new admissions to the building, would they have to be tested?
So that's usually a contract, right? Usually it's a contract.
But it's not through us. It's the contracts are through like the hospital.
Yep. Let me check on that. That's a gray area, I would say. I don't have an answer for that one, but that's a good one. Thank you.
Thank you.
Janine, it looks like there are a couple more questions in the chat
Sure.
box.
So how is the mobile X-ray tech coming here different from a tech in an X-ray clinic? It feels like a penalty for providing. I see what you're saying about a penalty for providing. If you have X-ray in your building, and then you need to get the documentation from a contractor. I will bring that up with CMS. What if the X-ray company is in a different county and the positivity rate is different than that facility? That's another good question. I don't have an answer for that one either. These are great questions. I wish I had an answer, but okay, I have both of those down. I don't know if there's anything else. I'm trying to see if I want to make sure I didn't miss anything. I think as Melissa opened up the call, this is fast and furious. And, I just want to thank all of you for the work that you're doing. I mean, I know that we're going on 6 into 7 months and all of you are just, in my mind, just heroes for what you're doing, taking care of your staff and your residents every day and having to deal with families and your own family too. So I just want to say thank you, as I can't imagine, how you get up every day and go to work and go into your organization and carry out your mission for your residents. So,
Janine, from your mouth to God's ears, and I couldn't agree with you more. And back at you. We know just from the nightly updates that I know from the nightly updates that I get from Ruth at LeadingAge National that you guys are working around the clock as this stuff comes at us. So our state-national partnership has never been more valuable than it is right now to serve our members. So thank you for all that you do as well.
Thank you. I'm very honored to have this position and this job and work for LeadingAge and all of you. So if there's a question that comes up or something you think about after, please feel free to email me. Or if for some reason you want to email Jody and both of us just to make sure we get it, please feel free to do that.
Yeah, you can also reach out to me. Janine and Jody and I are always talking quite a bit. So if you have a specific question, please feel free to reach out to me. This is Dana. I also wanted to mention before we hang up that we do have an MDS over PM transition webinar on October 7th with the Department of Health. The registration link for that went out in your reminder for the call today. So life goes on. We have other education that we are providing outside of COVID. So hope that you could be able to register for this. And Janine, thank you again. I echo Melissa's comments. Thank you so much. We just couldn't do this without LeadingAge National. We appreciate you getting on the call today with such short notice. I know everyone knows we canceled it, and then with all the questions that we were receiving, we felt the need to come again together today to address the topic. So thanks again, and the Department of Health for getting on with such short notice. So our next call will be on September 9th. We'll keep you posted about the topics, and just know that we're here. If you need us, please reach out to Melissa or me, and we're happy to help. Hope you all have a great rest of your week.
Great, thank you. Bye-bye now.